Earwax is normal, protective, and exists for good reason. It is produced by glands in the ear canal and mixed with skin debris. It's slightly acidic, contains enzymes, lysozymes, and proteins, immunoglobulins, that plays a role in preventing infections. In most people, wax moves outward naturally thanks to jaw movements and skin, epithelial migration, a self-cleaning mechanism. But when this mechanism fails or gets disrupted, that's when we see symptoms such as ear fullness, tinnitus, hearing loss, itching, otalgia, discharge, foul odor, even reflex cough due to nerve stimulation. Community workers can ask the patient to gently pull their tragus forward while you pull the pinna backward and upward. Use any available light, torch, phone, sunlight, to visualize the canal and look for wax. Otoscopy allows clinicians to look for dark, chunky earwax partially or totally blocking the ear canal. Consider predisposing factors like narrow canals, exostoses, hearing aid use, or prior surgery. They examine the ear using equipment such as otoendoscopes or microscopes. If earwax isn't causing symptoms, leave it alone. The ear is doing its job, but when it's impacted, causing hearing loss or leading to pain and infection, then community workers can start by explaining what earwax is and why cotton buds should be avoided, because they can push the wax further in, and recommend safe wax softening with 2-3 drops of clean cooking oil, pumping the tragus, and ideally lying on the unaffected side for at least 5 minutes, 2-3 times a day for 5-7 days. Avoid cotton wool since it absorbs the drops. If possible, re-examine the ear in a week. If it's still impacted, refer onward to colleagues who can help. Ear irrigation using a syringe is widely practiced and generally effective. But don't irrigate if the patient has a perforated tympanic membrane, prior ear surgery, canal abnormalities, or any symptoms during the procedure such as pain, bleeding, vertigo, or water from the nose. Always reassess after irrigation. Check for eardrum integrity and residual wax. How to perform irrigation? Ideally, first soften the wax using wax softening drops such as cold cooking oil for 5-7 days prior. Sit the patient upright with a towel over their shoulder and a basin under the ear. Tilt head and pull the ear upwards and backwards, then irrigate gently. Fill syringe with warm, sterile water. Place the tip at the canal entrance. Do not insert deeply. Aim slightly upwards and backwards and flush the ear canal. Allow the water and wax to drain freely. Repeat up to 5 times if needed. Re-examine the ear with otoscope. Look for drum integrity and residual wax. Dry the ear gently with a towel or use a few drops of rubbing alcohol to aid drying. Ear, nose, and throat professionals have more options such as manual wax removal and microsuction. Suction tends to be safer than irrigation. Management may need to be tailored to clinical context. For example, if the patient has diabetes, immunosuppression, anticoagulant use, or anatomical challenges. Complications can include tympanic membrane perforation, otitis externa, vertigo, canal trauma. If during any procedure a patient reports sudden pain, hearing loss, dizziness, or bleeding, stop immediately. If the patient has symptoms beyond a blocked ear, such as the ear is discharging or painful, suspect another cause other than earwax. Sometimes earwax can hide an infection underneath. Removing earwax can help to examine the whole ear properly.